Today I am going to present the longest day and the sleepless night, but basically it is not the longest day and the sleepless night, it is longest day and the quiet and cool and enjoyable night. I have tried to make the things
Just
as
opposite.
simple as possible. As you can see in this picture, one hero is there, that is Shah Rukh Khan, and he is playing the
Multi-bit.
different type of roles in the different type of movies. Like this, the lamella macular hole, the pathology. If we want to deal with any disease, we have to know the exact pathology of the disease. The exact pathology of the disease of all the vitreomacular interface disorder is posterior vitreous detachment, anomalous posterior vitreous detachment. And what is normal posterior vitreous detachment is the syneresis, the liquefaction at the center and separation of the posterior cortex from the retina at the same time. If there is a time difference is there, if syneresis liquefaction will be faster than the separation, it will lead to the all the vitreomacular surface disorder. Nobody knows which case will go into the lamella macular hole, which case will go to the pseudo hole, which case will go for the ERM, and we have named them, but the original pathology is the anomalous posterior vitreous detachment. It can lead to the vitreomacular adhesion, traction, full thickness, macular pseudo hole, or our today's topic lamella macular hole. We have given the name. They are not the different pathologies. We have given the name of a simple thing, that is abnormal posterior vitreous detachment. Now, today I'll talk about the uh, different technique to deal with the lamella macular hole. A few things about the lamella macular hole. The Wittgen's criteria for the lamella macular hole, only 4 are there. That is irregular foveal contour, defect in the inner fovea, intraretinal splitting at the outer plexiform layer. Outer plexiform layer, this is most important. I'll show in the video also how it happens. And intact photoreceptor, why the vision improves after the lamella macular hole surgery. So enjoy this video. One second. अभी तो copy किया था. Sound also. Audio. Audio please. Audio. है ऑडियो की. One second.
Typical epiretinal membrane, and on temporal side posterior vitreous detachment was present along with separation at outer plexiform layer. Following the extreme success of inverted internal limiting membrane flap technique by Michel Visca and extensive work by Chiode, surgeon decided to go for inverted ILM flap in this case too. The already given theory for lamellar macular hole formation is by vitreous separation and subsequent ERM formation leading to centrifugal traction. Surgeon has given a hypothesis that in tractional lamellar macular hole, main cause of vision loss is synaptic breakage at outer plexiform layer. Photoreceptors are most rigid cells in retina. Separation occurs at outer plexiform layer because in inner plexiform layer, more synapses per unit area are present. So if we remove this ERM traction and produce more pillars of Muller cells by ILM flap, that will lead to near normal foveal architecture and repeat synapse formation at outer plexiform layer. Surgeon started the surgery by intravitreal triamcinolone assisted PVD induction followed by posterior highlight and ERM peeling. After this, blind blue staining of ILM was done and peeling started with the plan to preserve a small piece of ILM for inverted flap. Unfortunately, ILM flap detached, so surgeon opted for plan B and took out a ILM piece and placed it over the hole with the help of color visco. After this, fluid air exchange was started. Just near the completion, surgeon found ILM flap was displaced from the hole and rolled over. So surgeon unrolled the flap with silicone tip cannula and perfectly placed it over the hole by the help of active suction of remaining visco from different directions. Surgeon named it as colored visco suction assisted ILM transplantation. At the end, air was replaced by SF6. After 1 month post-op, patient vision was 6/9 and N6.
In this LMH, pre-op best corrected visual acuity was 636 N10 and post-op best corrected visual acuity was 69 N8. So, color viscosuction assisted ILM flap placement technique is easy and reproducible. Thank you.
In fact, color viscosuction assisted ILM flap placement.
Typical epiretinal membrane and on temporal side posterior vitreous detachment was present.
I have tried in every macular hole surgery, and I am using this for the case of the inverted ILM flap also, and for the lamellar macular hole or any other case in which I have to put the ILM flap over the hole. What it is doing, it is giving the temporary tamponade on the ILM flap. At the end of the surgery, if you are doing the normal macular hole surgery, just tilt the eye towards the disc side, take out the colored visco, and because of the blue color, you can take out each and every drop of the color visco at the end of the surgery and replace it. The only problem in the inverted ILM flap surgery is to sustain the flap over the hole till the end of the surgery. So this temporary tamponade is very easy and it is very reproducible and no additional cost is there. The second thing I am going to
At outer plexiform layer.
The second thing is, problem is, in a case of PVR, if the oil has gone after the first surgery subretinal, how to remove the subretinal oil? In a normal case, the answer is you have to make a big retinotomy and retinectomy near the side of the oil, and then you have to take it out. Now I have used two things. One is the gravity. The second one is the immiscibility of the oil and the water molecule. So in a glass, if water is there, In a glass, if the oil is there and you will start pouring the water inside the glass, then the oil will come up because it is less denser. I have used the same phenomena in removing the oil from the eye in the subretinal space. Come here, please. In this case also, at the end of the surgery, I have found out a bubble of oil was there inside the subretinal space. So what I have done, I have pushed the saline in the subretinal space, and because my retinotomy was on the superior side at around the 12 o'clock. So I have chinned down, and because of this the water has gone towards the 6 o'clock and the oil has come towards the 12 o'clock. Just see how I have done this surgery. A small part. I am injecting the saline, and you can see the oil bubble is there. I am pushing the oil bubble with the help of the silicone tip cannula. This silicone tip cannot take out the oil, so I have removed the silicone tip, and by the active suction I am taking out from the steel tip. It will not collapse. So there is no need to make any other retinotomy or retinectomy, and you can take it out from a very small hole. You can use it in any type of situation. Just pushing it, the oil will come, take out from the existing hole.
So are you actively injecting the fluid, BSS?
If the hole is very small, I have to inject inside the eye, in the subretinal space.
So your assistant is injecting?
No, I am doing only.
Okay.
I am
and
doing
the
only.
oil bubble is coming spontaneously near the hole, and you are actively aspirating the hole by extrusion
No,
method.
first of all, if the oil is there, I have injected the BSS, the oil will come in the superior part.
Okay.
With the help of the silicone tip cannula, I am sweeping it towards the side of the hole.
And then you are actively aspirating it.
Then after that, I have removed the silicone tip, and from the steel tip, I am actively
It will
doing
easily
the
block.
suction.
Usually gets blocked. Easily,
The silicone tip will block, but not the steel tip.
Steel tip.